is Deborah Miller. I'm the Health Policy Director for the Council of State Governments from the National Headquarters in Lexington, Kentucky. We're doing a webinar today. We've titled it State Responses to Ebola Policy Lessons. And before I introduce our speaker, I'd like to go over a couple of webinar housekeeping items. All attendees to the webinar will be in a listen-only mode so that you don't have to worry about muting on your end. We've already taken care of that. Type questions into the GoToMeeting box in your screen on your screen at any time, and we'll get to as many questions as we have time for at the end. We will post the audio and the slides from this webinar on our Knowledge Center, CSG Knowledge Center, usually within 2 to 3 days. Those of you who have registered for the webinar, which you must have done to be in attendance here this afternoon, will get notice of that posting, and we encourage you to share it with your colleagues. So that takes care of sort of the housekeeping pieces. Our speaker today is Christine Kosmos from the Centers for Disease Control in Atlanta, Georgia. She is the Director of the Division of State and Local Readiness in the Office of Public Health Preparedness and Response, as I said, at the Centers for Disease Control and Prevention in Atlanta. She has more than 20 years of experience in emergency preparedness, planning, and responses in a variety of settings. She's held several positions dealing with preparedness at the CDC. She also has 20 years of experience with the City of Chicago's Department of Public Health. She is a nurse and started her career in emergency departments in trauma centers in Chicago. And we happen to know that today Christine is coming to us from Washington, D.C., where she has just received the 2014 Presidential Rank Award from President Obama. And so I was going to ask her before she starts her slides to get to pat herself a little on the back and tell us about what the award is, and then we'll get ready. So Ms. Kosmos, please.
Thank you. Thanks, everyone. Oh, it was no big deal, but thanks for the acknowledgement. It kind of really was kind of exciting to be nominated and selected. So so thanks for that. And it's acknowledgement of our work at CDC and really in our division, the Division of State and Local Readiness, which I'm going to talk about a little bit today, which in our mission really is to work with all of you at the state and local level to help prepare the nation for any sort of public health event or public health emergency. So I'm going to spend most of my time this afternoon talking about that. As you know, I've spent most of my time, honestly, at the state and local level. I've only been in federal government for 6 years now, and it's been a very interesting sort of an experience to do the majority of your work at the state and local level, mostly on the preparedness and response side, either from a clinician point of view in a hospital or on the public health point of view, and then to take some of those lessons and apply it on the federal level in more of a policy role. So it really does sort of round out, you know, a nice set of experiences, and hopefully people like myself who have had a lot of experience at the state and local level, when they come to federal service, really do have a little bit of a different point of view, and hopefully never sort of lose our perspective about what it is that we're really trying to do, which is really to help prepare state and locals, because, you know, we've heard it over and over again, all responses are local, and when we look at it through that lens, it really does shape a lot of how we think and how we plan, et cetera. So I just wanted to, you know, spend a couple of minutes today kind of sharing with you my point of view and how far we've come as a nation in terms of our level of readiness and our approach and our dedication to public health preparedness and response, and how we've really grown as a nation and in the public health system to appreciate the role of public health preparedness. I think that we always know what sort of traditional first responders do. Fire departments, police departments, paramedics, those are all things that are very, very familiar to us. And then public health preparedness has really been sort of a newcomer, if you will, kind of grown out of the ashes of 9/11. And I'll just share, for a minute my personal experiences post 9/11, where I was a deputy commissioner at the city of Chicago and saw everything that was going on. I was actually at home that day for taking care of windows that had lost the seal in my home, and saw that on TV and called some of our senior leaders at the city of Chicago and said, oh, we need to go back, we need to organize ourselves, we need to really think about what we need to do. And at that point in time, we were nowhere near the level of readiness that we have today. And after talking to some of my senior leadership at the city of Chicago and thinking about what we from the city of Chicago need to do in order to assure that our city was safe, and hearing back from our own leaders that no, there really isn't a role for us here, stay home, there just isn't any reason to come to the office, we're evacuating our offices. So you can imagine, fast forward, 15 or so years now, where we see things that go on across our country and we anticipate in a much different sort of way the things that are happening in other communities, which may in fact impact our own communities. Regardless, it's just a completely different mindset. It's a completely different level of readiness. It's a completely different point of view as to how we approach public health problems across the country. And the differences now compared to then are phenomenal. And we've taken some of those lessons, and it's helped us develop the level of readiness that we have currently for our Ebola response. And I'd like to kind of go into that a little bit. But let me go into the agenda slide and just share with you a couple of things that I would like to talk about. First, I want to talk a little bit about our division, because the division that I work has two functions. Not only we do preparedness, but we also do response. So I want to talk a little bit about our preparedness side, and then I want to talk about some of the emergency response to Ebola and the specific things that are going on now. And then if we have any time at the end, we can take a few questions. So next slide. So this slide you should be looking at says Division of State and Local Readiness, and it has a mission statement, which I won't read to you other than to point out a couple of words. That our mission in DSLR, the division that I work in, our mission is all about the nation's public health system and preparing the nation's public health system to be better ready to respond and recover. And in order to do that, we have to plan. So our everyday job in my division is for preparedness. And in CDC in general, our mission is about preparing and about having science rigor to the work that we do. And then in situations like Ebola, we put a different hat on. And we take all of the program preparedness work that we do, either in my division or infectious diseases or zoonotic diseases, any of the major divisions or centers within CDC, and we put a different hat on to apply a response mission to our work. So this is what our division looks like when we are preparing. We're working with our nation's public health leaders every single day to make sure that they are moving in a particular direction and continuously increasing and improving the level of readiness across the nation's public health system. So go to the next slide, please. This is what we look like every day in our preparedness mode, and that will switch when we talk about our response mode. So go to the next slide, please. And so this slide on the top says DSLR Preparedness Program Components. I think you probably know us best, our division, and some of the work that CDC does because of the funding that we give out to state and local public health agencies. Our division is the group that gives out the FEP, the Public Health Emergency Preparedness Cooperative Agreement, and that is the primary funding mechanism for state and local public health preparedness programs. We work very closely with our sister agency, ASPR, for the hospital preparedness approach or the hospital preparedness program, because that is hand in glove. We work hand in glove with our sister agency in order to assure that we have a level of readiness not only in the public health system, but knowing that the healthcare system is so intricately involved with public health preparedness, we work very closely with that agency. So not only do we develop guidance that goes out to state and locals, and we fund them, but in order to do that, we've designed and developed a program structure and a framework that we use to make sure that public health agencies around the country are all singing from the same sheet of music. And we do that through our national standards and capabilities. When I got to CDC, and one of the things that I think was really lacking in the public health preparedness world is, number one, there wasn't much of a public health preparedness world. We are a very new field. And one of the things that I think has helped and improved our programs over time is that we've brought a structure to our program and a framework from which we all agree and all operate. So can we go to the next slide? So before we go into all of the program components, one of the things that people ask us the most about is the funding and the level of funding that CDC is able to award to state and local agencies. And this is a refresher of things that you already know. But as you know, we get our money from Congress. Hopefully we will pass the budget this year. And that goes out to state and locals through to Health and Human Services, to CDC, and out to state and local public health agencies. And we work very closely with our partner 62 awardees to assure that each of those states and our directly funded cities are working to assure that their communities are have preparedness plans, that they have practiced those plans, that they've trained on those plans, that they understand what the risks are in their various communities, and they're working in a systematic fashion to mitigate those risks. So next slide, please. So I'm going to talk for a moment about our Public Health Emergency Preparedness Cooperative Agreement. And essentially this cooperative agreement, as I said, goes out to our 62 partners to strengthen national preparedness at the state and local level. We do that through our funding and our guidance throughout the year. We also do it through science and measurement of our programs, as well as our state and local partners programs. And we also work, as I said, on developing capabilities that really bring structure to our programs. One of the things that from when I worked on the state and local side that I thought we needed to work on once I got to CDC is that because we were such a young sort of a science, and because public health preparedness really wasn't recognized in a structured way much before 9/11, one of the things that I noticed when I was in the city of Chicago and working with all of my state and local colleagues was that we really didn't have sort of a common definition and a common understanding to what we thought public health preparedness brought to the table. What were the capabilities? How do we interact with our state and local partners? How do we work with law enforcement? How do we work with fire departments? How do we work with emergency management and homeland security? They really had been around a lot longer than public health preparedness, already sort of had their playbook. And I think those of us that were around post 9/11 really felt like public health preparedness really didn't have a playbook. We really weren't one of the traditional first responders. We usually didn't have a scene to go to. And so it was hard for us to sort of integrate and to get into the club, if you will. And in order to do that, I thought personally, as well as a lot of my colleagues thought, that what we needed to do was to develop a playbook and figure out how we added to the mission of keeping our communities safe. And we always sort of knew it in the back of our head, but we really didn't have a documented set of capabilities or criteria that we would use that defines public health preparedness. So when I got to CDC, we really sort of dug in and began to put structure and order around our program and began to define what was public health preparedness, what was our role, what were the capabilities that we needed to be able to do, what were some of the core competencies associated with that, what are some of the training needs, et cetera, et cetera. So on the next slide, which says Public Health Emergency Preparedness Capabilities Model, this is what we designed and developed for the first couple of years that I was at CDC, was to develop this playbook for public health preparedness, because we really were not really defined in a way that I thought, you know, added some structure to our program. So for 2 years or so, we developed capabilities model for what public health preparedness should be. So if you go to the next slide, which shows a picture of basically our document, I've called this everything from our cookbook to our roadmap to, you know, a list of our capabilities that we designed and developed over about 1.5 to 2 years with our state and local preparedness partners, as well as CDC subject matter experts, to say, what does public health preparedness look like? What is it exactly? What are we responsible for in our communities? And then how do we work with other partners to make sure that we're staying in our lane, working in our lane, and assuring that we are meeting the needs of our communities. So we defined our role in the following ways, using these 15 capabilities, everything from community preparedness and recovery to emergency operations, fatality management, information sharing, mass care, all the things that you see on your slide. And you may look at it, and I've gotten the question a lot, well, but, you know, EOCs do emergency operations coordination, and law enforcement does information sharing, and social service agencies do mass care, and, you know, and other volunteer agencies do volunteer management. And it does, and the thing that I always respond to those sorts of questions is that many times the capability has, it might have one owner, but it has many partners. So for example, in mass care, it might mean that public health doesn't stand up mass care operations, but we have a real role in assuring that when there are mass care settings, that public health is there making sure that there's that it's set up in a way that assures that there are no disease outbreaks, that it's safe, that it's clean, that it's free of infection and disease. So we've got multiple roles to play within these capability standards. But this is our framework, this is our guidance, this is our roadmap for what it means for a public health agency to be prepared. And so what we did is we rolled those out across the country so that all public health agencies that are accepting funding from CDC and for locals from their state are all playing with the same rule book, all have the same roadmap for how we build capabilities across the nation. And not everybody is in 100% agreement about what the capabilities are, but it's a consensus-based process that we use over the course of a couple of years to design something that is flexible enough to work for, you know, everywhere from, you know, Wyoming to New York City. And so there's plenty of room for flexibility within these, but it is a national framework and a national approach. So next slide, please. So our division sits in a larger center, but that center is all about assuring public health preparedness across the nation. And we work with our partners in the Division of Emergency Operations, our partners in the Division of Strategic National Stockpile, our partners in our Division of Select Agents and Toxins, and work in partnership to assure that all of these domains are addressed. But all of them have very much a focus on state and local capability and ensuring the safety of state and local communities around the country. So next slide, please. So what I'd like to show you is CDC as an agency. I think we've all grown so much since the early days of public health preparedness. It was a very rocky start. It was a rocky start for us in Chicago. It was a rocky start across the nation. But I think through the years, we have really sort of refined and honed our skill and our capabilities so that over time, we've been able to stand up responses, each one being different than the next. And this is just a snapshot of some of the responses that you've done at the state and local level and that CDC has activated its EOC in response of. The most recent in 2014, we'll have to add another bar here, is the Ebola response, and I'm going to spend a few minutes talking about that because once the CDC activates its Emergency Operations Center, our division, which during peacetime, if you will, is a division that's working on a daily basis with state and local public health on preparedness planning and assuring that what we've built at the state and local level is a public health preparedness platform for emergency response. So when I talked to you and I showed you the 15 capabilities, each of those works in partnership to develop what we are now calling our emergency preparedness platform. It is the thing that we use here at CDC for our responses, and it's the thing that state and locals use as well when they go from a preparedness sort of initiative to a response initiative. Those capabilities kick in and form our platform, whether it's the platform that you use for disease detection or getting messages out to your clinicians, letting them know about a new case definition, or whether it's sending out public health risk communication messages to the public. Each of those capabilities has a preparedness side and a response side as well. And so when we go into response mode at CDC, we kick in our own emergency response platform, of which our division becomes a member of the incident command structure, and we play a different role during emergency response. So next slide. So, and we do this, part of the thing that is the glue for our emergency response is our Division of Emergency Operations. They're the ones that stand up the response, that staff it, along with our division as well as divisions across CDC. They become a central point of contact for not only state and local partners, but also other federal partners that are involved in the response, everything from the White House to HHS to your recs that are sitting out in your communities. Our Division of Emergency Operations is staffed 24/7, and they field thousands of calls throughout the year for states who need a little bit of extra assistance in technical assistance, and they do that each and every day. But during response, can you go to the next slide? Our division, as I said, goes into a different sort of a role. So we provide leadership coordination within our incident command structure, and we provide consultation to CDC state and local partners at the state and local level, and we also become part of the incident command. So if you go to the next slide, I'll show you, this is what our activation looks like now. So once we've gone from preparedness into response, DSLR basically becomes the State Coordination Task Force. And in many cases, we are the face to a lot of our state and local public health preparedness partners because we are still working with state and local preparedness, state and local public health agencies each and every day. And this is the way that we organize ourselves, everything from planning to assuring that we have someone working within the EOC each and every day, to grants and funding. We are expecting some funding for Ebola response, and our group also, not only do we do the Emergency Preparedness Cooperative Agreement each and every day, but when there are emergency supplementals, our division working under this response framework also works on getting those supplementals out the door. And so let me go to the next slide and talk a little bit about specifically Ebola and what we are doing as an agency as well as what we are doing within our task force. So basically DSLR morphs into State Coordination Task Force, and in this particular response we are working primarily on the domestic side of things. So our work is very much domestic. We work with not only our medical care task force, who also has a big role on the domestic side, as well as our communications people, training people also have a big role on the domestic side. So the domestic piece of it kind of organizes itself in these 5 buckets of work. We are working with Medical Care Task Force and ASPR on development of the hospital strategy, the 3-tiered strategy, where we're trying to develop not only Ebola treatment centers, assessment facilities that can do testing, as well as frontline facilities that can isolate and assess for travel history to West Africa, and hopefully notify us at CDC or state and local public health agencies when they feel like they might have someone within their ER that has a strong history or could potentially be a person infected with Ebola. So we're working on designing and developing our hospital strategy and assuring our state and local public health agencies and our hospital partners are all prepared to deal and treat persons who may be infected with Ebola. We're also working very heavily on the active monitoring and direct active monitoring of travelers that come into our state. We're working on our funding of state and local public health agencies and make sure that you have the resources necessary in order to do this. We're working with our emergency medical services and designing and developing guidance that makes sure that EMS is safe and that there are plans for how we transport persons who potentially could be infected with Ebola. And we also work every day on the situational awareness side of things. So in terms of our domestic strategy, all of these sort of link together. There's a very sort of connected strategy for the domestic side of the Ebola response. And each of these, I call them sort of a multi-layered way of assuring that we've got protection for the American public. So for example, before anyone leaves West Africa, there is exit screening that goes on in the airport for anyone that is returning to the U.S. to make sure that there are no symptomatic people getting on planes. And then from there, when they land, wherever they land, there's also another screening process that happens to assure that, again, no one is symptomatic or that no one's developed a fever while in transit. And then once they land in the U.S., we funnel all of the travelers from West Africa to one of 5 airports. This makes it a more manageable approach and allows us to really concentrate resources in those 5 airports to assure that we do good screening of anyone that's getting off that plane and landing on U.S. soil. So once again, someone is screened and assessed for symptoms before they leave the airport. And they're also informed that they will be going through 21 days of monitoring to assure that they remain asymptomatic and don't develop fevers. And if they did, that they would have information about where to go and know that the public health agency within their state or local public health will be working with them and contacting them at least once a day to make sure that they are asymptomatic and to develop a plan with them for if they would become symptomatic, where would they go to receive care within the community. So, and then from there, we work with state and local public health agencies to not only implement their active monitoring and their direct active monitoring, and we ask them to report that to CDC and to help them, help our state and local partners if they have any challenges with contacting people. We did know that early on in the program, several weeks ago, that there was a lot of trouble with contacting people, and there was poor contact information on the form. So we were giving state and local public health agencies that information, which didn't help them do their job. And so working with them on the domestic side every day to better understand the challenges, we were able to implement some improvements in the screening process that hopefully has gotten a lot better and led to better contact information for travelers that were coming into the U.S. So we not only work with our state and locals on the active monitoring or direct active monitoring, and then from there, sort of using this theme of this connecting all the dots in this multi-layered approach, we've worked with then the hospitals to assure that the hospitals are ready, that they have the PPE that they need, that they have the training that they need, that we've designed and developed a manageable strategy within state and local, within the states to assure that I think our early message about every hospital should be able to manage an Ebola patient probably needed some tweaking, and since then we've learned a lot based on a lot of feedback that we received from our state and local partners that persons probably needed to be better managed and cared for at higher levels of care within the healthcare system. So we went back to the drawing board and designed a strategy which is a multi-tiered and multi-tiered approach that funnels people that potentially could be test positive for Ebola and triages them to the highest standard of care, much like we do with trauma systems or stroke centers or neonatal centers, using some of those lessons learned and making sure that we design and develop a healthcare strategy that assures that not everybody needs PPE, and that we direct the PPE and the training and the resources to the hospitals that need it the most. And so working with the airports to make sure that we have, that we connect people and that we screen people coming into the airport, screening them again for 21 days with our state and local partners, and then assuring that people who do become symptomatic have places to go where they can receive excellent care is all part of this interconnected strategy that we're working on with our state and local partners. And then, of course, adding emergency medical services into the mix, where we are also asking our state and local partners to work with their EMS services around the state to figure out who are the ones that you're going to rely on to transport people from one place to another. Do they have the training? Do they have the PPE? Do they have the right equipment? Are they capable of doing this sort of work? All sort of closes the loop and assures that all of the dots are connected at the state and local level, and that we have a system for managing Ebola patients and for managing travelers that potentially could become symptomatic. So I think, in summary, what we've done in our division during peacetime, during our preparedness role, is try to create these systems, create these platforms, and to create capability at the state and local level for doing excellent public health preparedness response. And then when we do move into our response mode, that we are connecting the dots and that we are using that systems approach to assure that we have layers and layers of protection that work together in partnership to assure that we keep our communities safe and that we have a very well thought out plan for assuring public health preparedness at the state and local level. And with that, I'm going to stop and take questions or concerns or comments. I will tell you one thing that I'm sure all of you want to know, and that is that the funding strategy is working its way through Congress. We've got a couple of different, well, actually several different funding strategies. We've got one pot of money that will go to state and locals to help offset the cost for active monitoring and direct active monitoring, and that is working its way through from HHS to CDC out to state and local. And that particular pot of money, although small, is not embroiled in all of the congressional wranglings that are going on right now. So that's one pot of money specifically for active monitoring and direct active monitoring of travelers. There's also, for our division, another pot of money and that's proposed to help general preparedness and response within the public health system. Everything from assuring readiness to EMS, to also helping offset the cost of active monitoring and direct active monitoring, to helping states on the epi side, and to assure laboratory preparedness, et cetera. So that will be a bigger pot of money, we hope, and will go out through DSLR, through our funding mechanism to fund state and local public health agencies. We also know that there are funding packages that are working its way through ASPR to work on the healthcare preparedness specifically. So so hang in there. There is light at the end of the tunnel, at least in terms of funding. But I will say, even despite the fact that there has not been funding specifically for Ebola for the state and local public health agencies, that the work that the state and local public health agencies have done in terms of tracking of travelers and working with those airports to do screening and working with their EMS providers and working with their hospitals to assure a level of readiness within the healthcare system has been amazing work. It's been extraordinarily impressive, and state and local public health agencies have really mobilized their public health preparedness response platforms and all the work that's gone on since the days of 9/11 to better ready the public health system has really paid off huge dividends for Ebola preparedness and response on the domestic side. So I just wanted to acknowledge the work that our state and local public health partners have done on this response, because it's been incredibly impressive work. So with that, I'm going to stop, and I'll take any questions or comments or anything you'd like to talk about.
Okay, we have just a few questions to ask. One is labeled quarantines. And with the legislative sessions coming up starting in January in most states, what should lawmakers be thinking about quarantine laws, or should they be looking at their state laws? Is there a model out there that they should be looking to enact?
Well, I would say, I mean, the thing that I learned and that we continue to learn with each and every response is anytime we enact any sort of plan, whether it's quarantine or healthcare systems, or whenever we enact anything and whenever we go into response mode, the most important and valuable lesson is to go back and look what worked and look what didn't work. And I think this has been an amazing response in the sense that every single state has had to think through their particular quarantine laws, and in some cases those laws have been on the books for a long time, probably don't get implemented or enacted very often, and it's a great opportunity to go back and see, are there things that you would want to tweak? Are there things that maybe worked better on the planning board and didn't work so well when you had to implement it? So I will say each and every state should really take a look back at this particular response, or also look at other states. There's lots of different models, lots of different examples out there, and I think it's worth doing a little bit of research to look backwards, not only within your own state, but other states as well, and to learn a few lessons and to see what it is that you would like to enact in your own state that works particularly well for you. And I don't think there's a one-size-fits-all model, but what will work for you? What are some of the things that you would like to enact moving forward? So I would learn the lessons learned, take a look at it, and moving forward, see what it is that you would like to fix.
Okay, and one other question was, you talked about the 15 capabilities. Is there a way for me and my state to know how well my state has done on those 15 capabilities? Is CDC evaluating my state and comparing it to another?
Yes, absolutely. That's a great question. So one of the things we ask our preparedness, so I would start with your state preparedness director. So every state has a preparedness director. Every state has a program. CDC last year invested $600 million in state and local public health preparedness programs, and every year we issue an award to every state to build their capabilities across their state. And one of the things that we ask our state preparedness programs to do is to benchmark themselves on the 15 capabilities, but to do that in a way that makes sense for your state. Everything has to make sense for your state. Every state has different risks. Every state has different needs. Every state can decide to what level they want to build a capability, depending on what the particular needs of the states are. So I would say there's no one-size-fits-all, and that each state needs to look at it in the context of your own needs. But every year, the state preparedness directors prepare for us a report benchmarking themselves against a national scale. And so you can look at that and look at your particular state and look at it in the context of how they're doing compared to their peers and figure out, do you need to invest a little more here, decide to put a few more resources over there. But it is a state-by-state thing, and there is no one right answer to the development of capabilities. But each and every year, despite the funding challenges associated with all programs, we have made incremental improvements across the nation in continuing to develop our capabilities. So I'm really proud of the work that the states have done. I'm proud of the fact that they've found ways to get to yes and to continue to improve the capabilities within their states, despite some of the funding challenges that we've had. And I think part of it is just understanding better what your particular risks are in your state and then designing something that works particularly well for you.
Okay, and the last question we have is from a state leader who says, I'm still asked in public, what are the chances of Ebola coming to our state? Do you have a suggestion as to how I should be answering that?
Sure. I think one of the ways that we're certainly approaching it is to look at the travelers that are coming in from West Africa. I don't think any state is immune, so there is a level of readiness and preparedness that we need across our nation because no system, I described all these various layers of protection that we've implemented, but nothing is perfect and everything is porous. So I think what we'd have to say is we understand that the majority of travelers that come back from West Africa go to a handful of states, 20 states, 25 states, and that half of the nation gets very few of these travelers. But not everything is perfect, and not everything, and we won't know. There might be some travelers that come into the U.S. that we have no tracking system on. We just know the ones that are coming in from West Africa that have what they call through CBP is non-broken links, where we can track a traveler from one place to another. But there could be travelers that spend a week in Paris and then get on a plane from Paris and come into the U.S. and no one knows because of their ticket that they originated from West Africa. So there will always be certain situations of people that come into the U.S. that won't be known to be originating from West Africa. So I think there's a level of readiness that we all have to maintain, regardless of whether we're a state that has a lot of travelers or not. I would also say that one of the things that we've noticed from this response that I think has worked well for all of us is it's made us extra vigilant about infection control and the sort of bread and butter that our healthcare system relies upon, which is good infection control every single day. And for that, I think that it's heightened our readiness. It's shown us when we don't pay attention to some of those things that bad things can happen, and that I think that we are at the end of this going to be in a better place across the U.S. healthcare system because we will have improved our infection control practices and our care of Ebola patients.
All right. Well, that took care of our questions for the day. Thank you very much, Christine Kosmos, for being with us from the Centers for Disease Control and Preparedness.
My pleasure.
Prevention. We really appreciate it. The webinar, as I said, will be posted on our Knowledge Center in the next 2 to 3 days. If you're still listening with us, you'll receive notice of that. And as we ask, please feel free to share that. Also, feel free at any point to contact us at CSG and ask us for webinars. Tell us what you like, what you don't like, what topics you're looking to get more information on. And with that, I think we'll conclude the webinar for today with, again, thanking our speaker. Thank you very much.
Thank you, everybody. Take care. Bye-bye.
Bye-bye.